Good afternoon, emus. How are you guys doing today? We're going to go ahead and do something that's really kind of interesting. We're going to talk about positive pressure ventilation. We're not going to go into the mechanical ventilation portion of it, but we're going to talk a little bit about CPAP or BiPAP. One of the things I wanted to introduce you to, and you may have heard about it, is called the iron lung. This is not positive pressure ventilation. However, this was ventilation for patients who, during the polio epidemic, lost the ability to breathe and be able to take care of themselves. As you can see, the only thing that's sticking out of this iron lung at this point is the patient's head. You had to take care of them. You know, you'd have to bag them or do some other things with them to keep them alive at that particular point. So this just happens to be a picture that talks a little bit about CPAP or sleep apnea. More than that, this is one of the main reasons we use CPAP is sleep apnea. Patients who have sleep apnea or people who have sleep apnea, if you know any of them, one of the biggest things that people complain about their spouses or significant others is that they snore, and they snore loudly. I call it rattling the walls of the house at that particular point. Sometimes they do have separate bedrooms. It's just a matter of what they can handle at that particular point. A lot of the folks, when you talk to them, if their spouse or significant other has sleep apnea, what they'll do is when they start snoring, they'll push them and turn them over on their side, and that seems to help a little bit with it. So what we're going to talk about, as we're bringing this up, is non-invasive positive pressure ventilation. Non-invasive positive pressure ventilation basically means we're not going to give them an endotracheal tube. We're not going to put them on a ventilator or anything at this particular point in time. With non-invasive positive pressure ventilation, there's three things that we actually talk about. The first one is continuous positive airway pressure, or CPAP. Like I said, this originally came out for folks who had sleep apnea, okay? What happens with this is that you set up a pressure that you get through a sleep study. It's put into the machine. This pressure, when the patient breathes in, is pushing the breath in. As the patient exhales, they exhale against that pressure also. Then we came up with bilevel positive airway pressure. We're going to talk about this. There's two different levels here. You have an inspiratory pressure and an expiratory pressure. Most often your inspiratory pressure is higher than your expiratory pressure. Matter of fact, the machine won't work if you try to reverse that, okay? And then the last one, this is what we all have in our lungs, and it's called PEEP, or positive and expiratory pressure. If you remember back in pulmonary A&P, we talked a little bit about PEEP. PEEP is there to help hold the airways open for us so that they don't collapse, makes it easier for us to breathe so that we don't run into problems with them. So originally, as I mentioned, CPAP was used for sleep apnea. What happens during sleep apnea? The tongue sometimes will fall back, the airway closes. These folks, like I said, will start snoring. And then what happens, that they'll all of a sudden stop and you don't hear the snoring anymore. And you look at them and it's almost like they're gasping a little bit for breath. And then they'll just sort of take a deep breath and then they'll start breathing again. When you do talk about sleep studies, Teresa's going to talk about that with you. One of the things we talk about is how many times during the night are these people actually waking up, okay? They don't get 8 hours of sleep. They don't get 6 hours of sleep. They are constantly waking up, and we count those wake-ups to try to figure out how bad their sleep apnea is. We also have nasal mask we can use for patients who have neuromuscular disorders. Sometimes what will happen with them is they can do well while they're awake, but if they want to sleep, either take a nap, go to bed, whatever, we need to be able to give them a mask to help keep that airway open so that they can breathe. Another one is, and we're going to talk about acute respiratory failure, especially when we get into fourth semester, we'll use that. That sometimes is being used to keep our patients from having to be placed on a ventilator. It makes it much better for those guys because a lot of those patients do not want to be on ventilators. So the question comes up at this point, what are we doing with CPAP and PEEP? What do they do for us? And in this case, as you can see, CPAP, which again is continuous positive airway pressure, we use it to improve oxygenation. It's going to take care of your PaO2 value on your ABG slip. And as you can see, it keeps the airway open throughout the respiratory cycle. One pressure goes in, the same pressure you exhale against. And what we do with CPAP, we have to adjust this for patient comfort. If you work in a sleep lab and you get folks ready so that they can start wearing CPAP, you don't go in and just hand them the equipment and say, good luck, call me in 30 days and let me know how it is. Sometimes it takes several hours for you to convince the folks that they have to wear it, get them to the point where they're comfortable with it, and make sure that they use their equipment. The newer machines that we have little chips in them. Some of them also have communication interfaces. And what happens is that with the chip and or the communication interface, this information is fed back to the studies, the labs, and they keep track of it. About once a month or so, if you have the little like SD card or something, you have to go back and have that read. Medicare will not pay if you're not using this, okay, equipment. So that's one way to track it. Excuse me, for the other hand, is used to keep the alveoli open. It too is used to improve oxygenation. The physiological PEEP we have in our lungs is about 5 centimeters of water pressure. So the question comes up, well, how does CPAP really, or PEEP, keep the airways open to help improve our oxygenation, okay? And what we're going to talk about with this, you guys remember when you took pulmonary diagnostics, you talked about the FRC, the functional residual capacity. What happens with CPAP or PEEP? It increases that for you. It increases it because we're getting better gas exchange going on at that particular point in time. It recruits alveoli, and what does that basically mean? Well, remember, alveoli can collapse. And if there's not enough pressure to keep them open, then we run into problems with it. By giving you CPAP or PEEP, what we're doing is we're opening up those alveoli, we're keeping them open. Once we keep them open, we're going to get better gas exchange, and this also increases the FRC. It increases oxygenation. Well, how does that happen? Well, what it does is once the airway and the alveoli are open, we have better chance to allow gas to go ahead in exchange, okay? We can exchange it, between the atmosphere and the alveoli. We can exchange it between the alveoli. Remember the Korsakoff and the canals of Lambert? That is the communication between the alveoli, and that will also allow for better gas exchange to take place. Because of this, and because of the fact that we've opened up the airways, we now decrease the work of breathing on the patient. They can breathe so much better, and it just overall is a really good thing. And so the question comes up, then what is BiPAP, and what does BiPAP do for us? Okay, BiPAP is 2 levels. You have IPAP, which is inspiratory positive airway pressure, and then you have EPAP, which is expiratory positive airway pressure. These are two separate levels, okay? IPAP is a higher level, so when the patient takes a breath, there's a higher pressure pushing that breath in. When the patient is exhaling, it's a lower pressure that they have to exhale against. Makes the work of breathing decrease also a little bit with that. These two levels each have its own job. In this case, IPAP, or inspiratory positive airway pressure, will improve ventilation. And ventilation, when we talk about ventilation, is always PaCO2. EPAP is the same as CPAP and PEEP. It's going to improve your oxygenation, and oxygenation is always PaO2. And how does that do that? You're still keeping pressure in the lungs. You're allowing for better gas exchange. You're decreasing that work of breathing, improving the FRC, all of those things that we talked about on that last slide. Okay. So the question comes up, what are some of the reasons that today the PowerPoint is not cooperating too well? The question comes up then, why do we use it? What are the indications for using CPAP and or BiPAP? And one of them is we have a lot of folks who will come to the hospital. They're breathing way too fast, very shallowly. They have some major problems going on. As a result of that, they will sometimes tell them or ask them, do you want to be intubated? They'll tell you no, they've either been on a vent before, or perhaps somebody in their family had been on a ventilator, and as a result of that, they don't want to be on one, but they will allow us to go ahead and use the CPAP or BiPAP. So we'll go ahead and use that to prevent intubation. Another one is your do not resuscitate status. We have folks who unfortunately are going to pass away. Sometimes they want to be comfortable. They know that this is happening. They're working too hard with their breathing, too much work of breathing at that particular point, decreased oxygenation, and we're going to make them comfortable by putting them on the BiPAP or the CPAP machine. Patients who have COPD, patients who have asthma, saw a little bit of that with your diseases. These are obstructive diseases. What happens is they can get the air in, but they can't get it out. They have a great deal of air trapping. Especially with your patients of COPD, we don't want to intubate those folks. If we do, we have a hard time sometimes getting them off our ventilators. And so rather than trying to put them on ventilation, we'll put them on CPAP or BiPAP. Patients who have asthma, once their asthma hits status, which means that there's hardly any gas exchange going on at that point, they're almost what I call a nightmare to be able to ventilate. We need to catch them before they get to that point, and CPAP and BiPAP will help us with that. Another postoperative respiratory failure. I don't know how many of you guys have had surgery, but when you come out, depending on the amount of anesthesia that you've had, sometimes you don't want to breathe, and we definitely want you to breathe. And if we are intubated, we definitely want to take the ET tube out, and so in order to help you with that, we can use the CPAP or BiPAP at that particular point. Nocturnal hypoventilation, this is called Oldine syndrome. Oldine was a goddess who lived in the days of the gods and the goddesses. She was a very nice young lady, very good looking. She came to Earth. If you're into Greek or mythology, she found a mate, human mortal on Earth. The two of them got married. She had a couple of kids. She lost part of her figure, so her husband decided to go out and look for somebody else to satisfy him. Okay, and unfortunately, she found him in the haystack with this person, and she decided, Odine did, that she was not going to kill him, but she basically told him, when you go to sleep at night, you will stop breathing. And so that's where nocturnal hypoventilation comes from. And then the question comes up is, well, who are people that we would actually use this? Are there requirements for this patient in order to be able to use CPAP, BiPAP? And the answer is yes, there is, okay? A good candidate is one that we call awake and alert. You guys hopefully are awake and alert listening to this presentation. Sometimes, though, with the patients that we deal with, we wouldn't say that they're really awake and alert. They have their eyes open, they're listening, they may nod when we ask them questions. However, since they don't want to be intubated, but they're looking for some help, we call that awake and alert. A really big one is they have to be able to protect their airway. If they have a lot of secretions and they're coughing the secretions up, but they're not getting them out, once we put this pressure on them, these secretions are going to be pushed back into the lungs, and we're going to have another problem on top of the problem that we already have. And so if they can't protect their airways, they cannot manage their secretions, they're not candidates for CPAP or BiPAP. This one is almost like, well, Louise, this is a duh. Of course they have to be able to tolerate the equipment. This is where your job comes in. As I told you or mentioned to you, and I should have mentioned to you, it sometimes takes hours to convince people that they have to use their CPAP. And they have to use it because it's going to help them with their life. It's going to help them, with their family, whatever else is going on with their at that particular point in time. When you first go to put CPAP or BiPAP on a patient, you're pushing a pressure into them, and that pressure can be very uncomfortable. And so what we have to do is we have to convince these folks that they need to wear this, and then we have to work with them to be able to get them to try this. And what we'll do with this sometimes is we'll what they call titrate. Remember, titrate means you can either go up or down on this pressure, and we'll do it until the patient can tolerate it. Once we have the equipment on them and they're comfortable with it, then we can increase the pressures if we need to at that particular point in time. So it doesn't, it's not one of these things that you're going to go into the room and you're going to be out in 5 minutes. Like sometimes you may be in there for 45 minutes or longer talking to these folks, and so they can tolerate this. At the same time, if their family members are in the room, you need to also address those folks also, because sometimes they're the ones who may be telling the patient, oh, this looks really uncomfortable. I'm not quite sure you're going to like it. We don't need to be hearing that, and the patient doesn't need to be hearing that. So we always have to be positive. We have to be proactive and say, this is really, really good for you. We're going to make it to where you're going to really like and enjoy this. When you wake up in the morning, you're going to feel so much better, and everything is going to look much better, much more rosy at this particular point in time. We want the patient to be conscious so that we can talk to them. We want them to be cooperative so that we can actually work with them, okay? If you have a patient who's already made up their mind that they're not going to do this, and that anything that you do or say is not going to work, you cannot sit there and change their mind. Then unfortunately, they're probably not going to be wearing their CPAP or their BiPAP. If you're going to wear this for an extended period of time, one of the things you're going to find out, and I'm going to say longer than 24 hours, okay? When you're blowing that gas into them with that pressure behind it, not all of it's going to go into your lungs. Some of it's going to end up in your stomach or your GI tract. As that happens, now you're filling up your GI tract, okay? And that can also be very uncomfortable. So what we like to do is to remove that excess air and pressure if we can, and we're going to have the nurses use a nasogastric tube to go ahead and decompress the GI system. If you don't, there's going to be other interesting things that are going to happen with your patients. Okay. So in this case, then who is not a good candidate? You know who your good candidates are, but now we need to know who are not good candidates. And one of these is apnea. If you guys remember, apnea is the sensation of breathing, okay? We're not talking about 5-second apneic periods, okay? We're talking a little bit longer apneic periods at that particular point in time. But we're going to work with those patients so that they can actually breathe if we can do it. But if you have somebody who is having a 5 or 10-minute period of apnea, they're probably not going to be a really good candidate for CPAP or BiPAP. A patient who is coded, if you have a patient, remember a patient who is coded is one that no longer has a heart rate or respiratory rate. We just don't put them on CPAP, BiPAP, hope for the best. We're going to go ahead and do CPR, whatever else we need to do at that point. If they have come back, most of them are going to end up on ventilators or something else to keep them alive at that point or keep them going. Hemodynamic or cardiac instability, we haven't talked a lot about this, but if you have a blood pressure that's all over the chart, if you have a heart rate that's going from high to low, you have different things along that line that are happening to your patients, they are definitely not a good candidate for CPAP or BiPAP. Because when we use CPAP or BiPAP, it is going to affect your blood pressure, it's also going to affect your heart rate, and so we need to make sure that at least you're stable at that point. When we use CPAP, BiPAP in the hospital, most of the time, we're actually using nasal masks. I'm going to show you one of them. We have some pictures of them as we go through. Because of that, if you have a facial burn or even facial trauma, a lot of times we can't use the mask. One of the things you'll find out is people who use CPAP, BiPAP at home, they like whatever their interface is. Some of them are using what we call nasal prongs. Some of them are using other newer ones on the market. Those are all home care, and they have to get these through their home care providers. When they come into the hospital, a lot of the hospitals will not let these folks bring their equipment in. Part of the reason is sometimes that equipment is not clean. We also may find out it doesn't interface well with our electrical systems. What we can offer them is a nasal mask, and some people really don't like that. But however, we have to work with them. Again, if we cannot protect their airway, manage their secretions, we don't want to have aspiration going on. They're going to end up with aspiration pneumonia, and then we're going to have another number of problems that we don't want to have to deal with. Copious secretions go along with that. Also, anatomical abnormalities that are going to not allow us to put these masks on. Say, for example, their nose is where their ear is. There's no way that we're going to be able to put a mask on them at that particular point. There's also what we call absolute contraindications, and we're going to see this with some of the different things that we do when we talk about therapeutics too. If you're in a coma, you are not awake, you're not alert, you may not be spontaneously breathing. That's another thing. You have to have spontaneous breathing going on to wear either CPAP or BiPAP. If you've had cardiac arrest, respiratory arrest, there's your code in some cases, or you could just have a cardiac arrest and still be breathing. The same with a respiratory arrest. You may not be breathing, but you still have a heart rate. We're definitely not going to put you on CPAP or BiPAP. If there's anything going on that requires us to intubate you, for example, say that your trachea has been crushed and we need to help you breathe, to keep you alive, and we need to intubate you at that particular point in time, CPAP, BiPAP is not a step on the way. We have to immediately go to that intubation. Okay, so then how do we determine how we're going to set this up? CPAP studies we get from sleep studies, okay? There's a lot of sleep labs around the country. There's a lot of sleep labs here in Tucson also. And one of the folks one of the things that people think is if you're going to have a CPAP study and a sleep study, that it has to be done at night. Sleep labs also work during the day because you have to take into account the day shift and the shift workers, both day shift, night shift, whatever. And so at that particular point, it'll be set up so, excuse me, during your normal sleep time to have this sleep study done. IPAP settings come from the physician. There, the physician has come and said, I want you to go ahead and set this patient up on BiPAP. Remember, CPAP takes care of oxygenation. BiPAP takes care of both ventilation and oxygenation. And so if your patient has a high elevated CO2 and their PaO2 is not all that great, BiPAP is really what we need to look at this particular point in time. So the doctors will give us the orders. You'll see them written, as you can see here, 12/5. It will see BiPAP 12/5. Well, what that basically means is we're going to set the IPAP at a pressure of 12. We're going to set the EPAP at a pressure of 5, okay? These are the settings that the doc is hoping that the patient will wear once we get this on the patient. We can titrate these settings down. Once we have the equipment on, we're going to talk with this patient. How are you doing? We're going to look at them to see how well they're breathing. Are they beginning to calm down? We're going to ask them, do you feel like, again, do you have enough air? If not, we're going to increase those settings until that patient is comfortable. So what are the most commonly used settings? We normally start BiPAP around 8/5. Remember, 8 is the IPAP, 5 is the EPAP. When we increase it, we can increase it in increments of 2 to 3 centimeters of water pressure. So if I have a problem with my PaCO2 and my oxygen is okay, I can go up to 10 or 11 on the IPAP and still leave my EPAP at 5 because the oxygenation is okay. If I have a problem with both of them, I'm going to increase both of those, the 2 to 3 centimeters of water pressure. And we're going to talk about this. This is just an intro for you guys to take a look at. As you can see too, we're going to talk about titrating for patient comfort. We need this patient to wear this equipment. How are they going to wear this equipment? When are they going to wear this equipment? It has to be comfortable for them, okay? You cannot put a mask on them and allow the mask to leak into their eyes. They are not going to wear it. You also can't put a mask on them and over tighten it. If you over tighten it, you're going to go ahead and have skin breakdown or necrosis. If you make the mask too loose, you're going to have a lot of leaks, and at that particular point, it's not going to work also. What do we want to see? We want to see an improved respiratory status. We want to see an improved cardiac status and an improved neurological status. The same things we want to do when we're trying to give you oxygen therapy, okay? So if you remember with oxygen therapy, we're trying to improve the cardiopulmonary status of our patients, the neurological status of our patients at that particular point in time. So this is a older model. This is one that we used to use when I was in the hospital. It's called a BiPAP ST, which is spontaneous in time. That's what it means. You can see the tubing. It's a little older tubing, and there was a mask. These masks were somewhat uncomfortable. The little piece that's on the top part up there was very, very hard. We used to put it against the patient's head to try to get it to fit. And the masks weren't made of a very soft plastic or anything like that. They were kind of hard also. We also had a monitor that we could use. We could monitor the patient's tidal volumes. We could monitor the patient's pressures. The nice thing about these, the older machine, if you notice, it didn't have that bottom part on it. The settings are on that one side that's in the green areas. People had to know where to go get them to play with them. So if the family members came, one of the things we didn't have to worry too much about were people making adjustments to the BiPAP levels or the IPAP, EPAP levels. With this one, sometimes the families would come in, they knew where it was, and they could start playing with it. But this is how it looked on the back. 3 different levels. One was totally spontaneous. One was spontaneous timed. Time meant if we're only getting 4 respiratory rates and we need more, we can set the backup so to where the patient would get the additional breaths per minute. And then the last one we used is how long do we want to keep the patients in inspiration. Most of the time we didn't do that, but we had ventilators that we actually did that with. This is a patient, this is a newer model. This is the BiPAP Vision. You can see it has a whole lot more graphics with it. We still use this. It works beautifully, okay? You can hook this up to oxygen so you don't have to worry about it. The older one that you just saw, if we wanted to give the patient oxygen, we had to bleed it in. We had to set up tubing to the oxygen flow meter and then get a adapter to go ahead and put the oxygen into the tubing and give it to the patient. How did we do that? We would put sometimes the adapter back by where the BiPAP circuit hooked up. Other times people would put it close to the patient's face. Sometimes they would put it with them in the mask. And so we were blowing all this additional air into the patient at that point if it's that far up. This patient is kind of interesting. He has a trach, and he still has a nasal mask over his nose, so he's able to breathe around his trach. There are people who have sleep apnea that really have no neck and they can't breathe and the machines don't work very well for them. That what they'll do sometimes is they'll trach these patients and then they'll go ahead, when they sleep at night, they'll hook their CPAP, BiPAP up to their trach. Okay. So anyways, one of the complications of having sleep apnea is when you wake up in the morning, you have a headache, and the headache is a result of the high CO2 levels. So some of the complications of BiPAP or CPAP is facial tissue damage. One of the areas, if you feel across the top of your nose, you can feel the bony area. There's not much skin covering that area. If you put a lot of pressure there, it takes you about 24 hours to necrose that area. Gastric distension, talked a little bit about that. You have to have a nasogastric tube to try to decompress the stomach so that you don't have emesis or other things that are happening to you at that particular point. Eye irritation, if you're not careful with the mask, sinus pain or congestion. This can be very, very drying. A lot of these had humidifiers. Sometimes the patients were like, I don't want to mess with the humidifier. They will after a while because it gets very, very dry, and they will have that problem. Hemodynamic complications, if we put too much pressure in the airway, what's going to happen is we're going to put pressure on the vessels. And when we put pressure on the pulmonary vessels, we're going to decrease the amount of cardiac return, and we're also going to decrease the amount of cardiac output. So one of the things we always have to watch for is to make sure these people keep their blood pressures for where they need to be, and that they do have good venous return and cardiac output. So these are pictures. As you can see, there are pressure ulcer on the nasal bridge, and then you can also see pressure ulcer on the cheeks at these points. What happens is if you're putting these masks on too tight and you're not checking them, that pressure is actually going to necrose that tissue. So what are some of the patient interfaces we have? We have our nasal mask, we have our nasal pillows. Our nasal pillows are almost look like your nasal cannula, except that the two prongs are much wider. Full face mask. Some patients like the full face mask. We have new ones that they can actually not see the end of the face mask on their face. It's outside their peripheral vision, and people like that because they don't feel like they have anything on. They're a lot more comfortable than they used to be. There are mouthpieces that folks can wear that'll help you. The important thing to remember is when you have CPAP, the gas is being delivered in and out of your nose at that point, if we have a nasal mask on or anything, and you have to keep your mouth closed. If you don't keep your mouth closed, the gas will go right in your nose and come right out your mouth, and none of it or hardly any of it will ever make it down to the airway where you need it. So if you look at the picture in the lower portion of it, you see someone who has a nasal prongs, and then they have this black strap on. That strap is keeping their mouth closed. There is a helmet, believe it or not. You'll see that on the next slide. There was a research article that came out about 2 years ago, and it talked about that patients actually did like the helmet. And when you look at it, you go, oh, okay. Let me show you that. There you see. And this picture of this person was in that research article as far as that goes. But you can see it is a helmet, and that the strap goes underneath the arms, and that's what the patient is wearing, is their CPAP BiPAP at that particular point. So again, starting CPAP BiPAP, first and foremost, always check your orders. Always check your orders. Make sure that you have the right patient. What happens sometimes in the hospital, patients get moved around, they go to other rooms. Sometimes they do get discharged, and we weren't aware that they were going to be discharged. So always, always, and forever check your orders. The second thing is, if you remember from patient assessment, 2 identifiers. Who are you? Look at the wristband, ask the questions, do all of that stuff that you need to. It's sometimes beneficial to get some help, especially if you're uncomfortable with this or you haven't done it for a while. Find somebody else. You always want to have a good mentor when you're working in the hospital to help you with this so that you can get this set up. Talk to that patient. Talk to that patient. You need to tell them, hi, I'm Louise from respiratory. You're having some breathing problems. Your physician or your doctor wants us to go ahead and give you a device. It's called CPAP or BiPAP. It's going to give you some extra air that's going to blow in. It's going to help open up your airway, keep your airway patent or open for you. And we're going to go ahead and tell you what we're going to be doing. I'm going to show you what the equipment looks like. I'm going to let you feel the air before we put it on you. Go through the whole thing. Talk to them. Tell them what you're doing. Do your assessment of them. I want to listen to you. I want to take your blood pressure if I need to. I'm going to take your heart rate. I need to know what's going on with these patients, okay? The mask, when they come with a measuring device on them. They used to have a circle that you used to use, but now we're not doing that because of infections and things like that. So the masks actually come with the measure device on them. The thing about it is most people wear somewhere around small. Some people do wear small medium, small petite, things like that. People who are 6 foot tall will tell you, I've got a big nose. And you go ahead and measure, and they still have a small nose too. So your size sometimes has nothing to do with the size of the mask we're going to put on you. So here's the equipment. Remember, this is the one that we worked with at the hospital, and you can see the mask. This is more of a full face mask also. So it's going to cover the nose and the mouth, which is good because at least we'll keep the mouth closed at that particular point. So we're going to let the patient see the mask or the interface. Very important for us to do that. Turn your equipment on, set your parameters. You want to make sure that this is set up as much as you can before you go into the patient's room. Worst thing you can do is go in the patient's room, tell them, I'm going to go ahead and set this all up for you, and then you start fumbling, or you drop the mask on the floor, or you step on the tubing or something like that, trying to get it put together. The patient is not going to be trusting of you, and you have to leave and get new equipment. So you always want to try to set up as much of this as you can outside the room. So let the patient feel the flow. This is what it feels like. If they can hold the mask, you can let them hold the mask and put it up to their face. If you see them backing away from it and trying to put their head through the headboard, obviously there's too much flow. So titrate it down until it's comfortable for them. And there it is. You're going to decrease it, okay? And then titrate for comfort. Do you feel like you have enough? No, I think I need a little bit more. Okay, we're going to turn the pressure up. Say we went from 8 to 5. At that particular point, I'm not necessarily going to go from 5 to 8. I might go to 5 to 6, 6 to 7, and then 7 to 8 if the patient tolerates it. So we want to make sure that we make this comfortable. The most important thing is having the patient on the equipment. Once you have the straps on, and you can see the straps on this young lady, you want to make sure you can put 2 fingers between the head and the straps. This is what's going to keep it from getting too tight. Okay. Check for leaks, tighten if you have to. You tell them they need to keep their mouth closed. If you look at the bottom strap, you can see it goes below their ear. You want to make sure that that goes below their ear. You also want to make sure, and I don't care if you're a male or female, if you have pierced earrings, make sure that those earrings aren't being put into your head, okay? You may have to ask the patient, can you take your earrings out? Can we take your earrings out? If you do that, make sure you give it to them. Make sure you tell them that you get, the nurse that you gave it to them. If you gave them to a family member, that they were given to a family member. You don't want somebody coming back and saying, you stole my diamond earrings, and they're actually cubic zirconium, okay? The other thing is when you're putting this on, they may have to take their glasses off, depending on, how this mask fits. Once you get them set up, if they need to put their glasses back on, then they can do that at that point. Okay, so there it is, the 2-finger rule. When the headgear is attached, it should be possible to pass 2 fingers beneath it. So as everything we do, you do have to document, okay? And as you can see, the first thing you want to document is that the patient was trying to strangle you. So be careful about that. One thing to think about when you go to the hospital, don't be wearing your stethoscope and your name badge around your neck unless it's a breakaway name badge. Patients, if they're trying to fight you or fight somebody else, will reach out and they'll grab your name badge, they'll grab your stethoscope. When they do, they don't sit there and go, oh, I'm so terribly sorry, I didn't mean to do that. They have a tendency to hold on to it much tighter, and you're sitting there turning blue, so be careful of that. So what do I want to document? I want to document everything that's important, okay? The date and the time, okay? When did I do it? What time was it? And remember, when we document in military time, 24 hours, okay? We're going to document the pressures. If it's a CPAP, what is it, okay? If it's CPAP, what is the CPAP pressure? If it's BiPAP, what's the pressure for the IPAP? What's the pressure for the EPAP? We're going to also document what type of interface does the patient have on, because who knows, the family may come in and say, hey, we brought your nasal pillows, and pull your mask off and throw the nasal pillows on there. So you have to make sure that you understand and that everybody else understands what you did with this patient. The size, the patient level of comfort, are they wearing it? There's no leaks going into their eyes. There's not a hurricane going around their face, anything like at that particular point in time. If you have oxygen being bled in or it's hooked up to oxygen, what's the FiO2 at that particular point? If you have the alarm set, what are the alarms at that particular point? If you have a backup respiratory rate, you also want to make sure that you document that. Vital signs. What is their heart rate? Remember, before you started, you took your vital signs. And now what you're going to do is you're now going to take them post putting the patient on them. Because what we're looking to see is, have we made an improvement in this patient? Remember, that's one of the goals of oxygen therapy: get a better cardiac status, a better pulmonary status, a better neurological status. And we need to be able to make sure we document all of those. If you're talking to this patient and this patient sits there and mumbles in between the breaths, this feels good, make sure you document that too, okay? And also remind the patient that you don't want to talk because the gas will come out your mouth at that particular point. This is a new one. This is the V60. We see a lot more of the V60s. These are a little bit more fun than the other ones. You have a touch screen plus a little thing on the top that you can run your finger around and set your settings up at that particular point. There are masks that go with it, made by the same company. Sometimes we do get different masks from different companies, and all we do is basically learn how to go ahead and set it up and prevent the leaks and everything. It has some of the bells and whistles on it that are really, really neat. It tells us tidal volumes, it tells us pressures, it tells us a lot of things at that particular point in time. So this is one that when you go to clinicals, you'll probably may see this at the hospital. You can see this person is setting things up on it too.